Hello and welcome to today's webinar. Today's webinar is hosted by BioReperia and Mount Sinai. My name is Gabriela and I'm project manager at BioReperia, and I will be your moderators for today's session. And today's webinar will run for approximately 45 minutes, and this webinar is being recorded for later viewing on our YouTube channel, where you can also find recordings of our previous sessions in this webinar series. For a smooth experience, please keep your cameras and microphones off during the presentation. If you have any questions, just feel free to type them in the comments section and we will address them at the end of the presentation. So today's webinar is titled Advancing Prostate Cancer Targeted Therapy, Breakthroughs Using Zebrafish Tumor Xenograft Models. And we have two keynote speakers for today's talk, and we are excited to welcome Dr. Sujit Nair. He is Assistant Professor and Director of the Genitourinary Immunotherapy Research at the Icahn School of Medicine. And Dr. Nair is renowned expert in chromatin biology, cancer immunology, and genomics, leading groundbreaking research into the tumor microenvironment and immune system responses to therapies. His work spans diverse ideas, including racial disparities in prostate cancer, drug repositioning, and the integration of artificial intelligence in precision oncology. He also plays a key role in immune therapy clinical trials, including a personalized genome vaccine for prostate cancer. Our second keynote speaker is Dr. Lasse Jensen. He's a senior associate professor at Linköping University and chief technology officer at BioReperia. Lasse is also one of the founders of BioReperia and inventor of the Zebrafish Tumor Xenograft platform. And his research at Linköping University focuses on finding the mechanisms that lead to disease-promoting blood vessels growth in the eye disease and cancer, and understanding why the patients respond differently to the same type of treatment. So without further ado, Sujit, I will leave it to you.
Thank you, Gabriela, for the kind introduction. So good morning, good afternoon, or evening, depending on where you're joining us from. Thank you for taking time from your busy schedules to be here today. I'm here representing a team of dedicated collaborators and brilliant minds who have contributed extensively to this study. So today's presentation is divided into two parts. First, I'll briefly discuss the research on novel therapeutic drugs from Palisade Therapeutics, highlighting some key findings in prostate cancer. Then I will hand it over to Dr. Lasse and Dr. Gabriela, experts in zebrafish model, to delve into the in vivo studies with PT drugs. Now, let's begin by examining the motivation and a focus on prostate cancer. I'll start with some key statistics that underscore the urgency for our research. So according to the Lancet Commission, worldwide prostate cancer ranks as the most common cancer among men in 112 countries. It ranks as the second most common cause of cancer mortality in males, surpassed only by lung cancer. It represents approximately 15% of all cancer diagnoses. Now, if you consider the statistics as presented by the American Cancer Society for 2024, the projections are for 35,250 deaths. 1 in 8 men are diagnosed in their lifetime, 6 in 10 men diagnosed above the age of 65, and 1 in 43 men will die from prostate cancer. What makes it even more concern is that prostate cancer incidence is 70% higher, and mortality rates are notably greater in Black men than white in the US. Now, the crisis continues to grow, and the numbers are on the rise because, according to the Lancet Commission, the incidence will double from 1.4 million new cases per year in 2020 to close to 2.9 million cases per year in 2040. And so will also the deaths due to this disease. Now, having considered these alarming and compelling statistics, it is clear that we need very innovative solutions to address this growing challenge. And I've listed here 5 strategic ways that we could target this disease. The first is early intervention, which involves prioritizing early detection and timely treatment to improve survival rates and patient outcomes. There's an emerging need for neoadjuvant new strategies with new pharmaceuticals that can prevent disease recurrence and enhance outcomes. Advancement in drug development. This involves introducing new pharmaceuticals that enhance the efficacy of existing standard of care, including androgen receptor signaling inhibitors, either in the adjuvant and the neoadjuvant setting. Combating the metastatic disease, that is especially important in the patients with metastatic castrate-resistant prostate cancer because it's fatal. And an holistic care approach, which integrates patient-centered care models to improve quality of life and treatment compliance, ensuring a comprehensive fight against cancer. My presentation today is centered on the three of the point number 2, point number 3, and 4 of this strategic approach. I would be remiss if I don't discuss the androgen receptor signaling pathway, which is the critical and very central to not only for prostate development, but also plays a critical role in prostate cancer. So as some of you may know, the prostate cancer, androgen steroid hormones bind the androgen receptor and trigger a key lineage-specific oncogenic transcriptional program. And for many decades, this fact has been therapeutically exploited to treat de novo metastatic disease or recurrent metastatic disease after initial surgery or radiotherapy. Although androgen deprivation therapies and AR signaling inhibitors prevent further tumor growth for a while, most patients develop resistance to treatment, resulting in metastatic castrate-resistant prostate cancer. This results due to reactivation of AR and/or AR modulating strategies. Thus, novel AR targeting strategies are sought after, and that not only block full-length and AR variants, but also introduce PROTAC that are in various stages of clinical development. So, building upon the critical role of AR signaling that plays a crucial role in prostate cancer, we now turn to an exciting aspect of our collaboration with Palisade Therapeutics. This slide here explores how these compounds, namely the PT150 and 157, can be strategically leveraged to fight against prostate cancer. Both these drugs are developed in collaboration with Palisade Therapeutics, are prime examples of how targeting AR pathway can lead to innovative treatments. These drugs not only complement traditional therapies, but offer new hope for the battle against prostate cancer. So PT150 is a clinical stage drug that belongs to the class of psychopharmaceuticals originally developed for depression. Its primary developmental pathway has been as a treatment for neuropsychiatric diseases characterized by dysregulation of the hypothalamic pituitary adrenal axis of signaling that are often associated with higher than normal circulating levels of endogenous cortisol. It has completed 15 phase 1 and 5 phase 2 studies for CNS indication. PT150 has excellent safety profiles. PT157, the second drug that I will talk about today, is a dimer of PT150. The PT150 and PT157 have potent anti-cancer activity. This has been shown through collaboration with National Cancer Institute, screening a panel of cancer cell lines. Both PD150 and PD157 showed excellent activity, anti-cancer activities. PD150 and 157 inhibit cell proliferation, and what we've shown and what our ongoing studies are showing is that it's a potent AR signaling inhibitor. It not only blocks the androgen receptor pathway, but also blocks the glucocorticoid receptor pathway. Just to summarize, because this is pending publication, and while the focus of this webinar is mostly to showcase how PT150 and 157 has been studied in vivo model, through this slide, I'm just going to give you an overview of what we found so far. It has both PT150 and 157 has robust anti-cancer effects. It's demonstrated by ongoing studies. These drugs effectively cross the blood-brain barrier, expanding the potential therapeutic effects. Research done by collaborators have shown that they have dual immunomodulatory effects. They have hormone and viral defense modulation. Our ongoing studies are focused on mechanistic studies that elucidate how these drugs function, and what we're trying to narrow down on the exact mechanism, but it apparently looks like it's functioning through the ubiquitin proteasomal pathway, and also sort of hijacks the metabolic pathways that are critical for cancer progression. And some of our continued research and upcoming insights will be provided through our publication. So having seen very potent in vitro effects, our logical next step was transition to in vivo models. And what comes to mind is testing these drugs in a mouse model of prostate cancer. And while we were contemplating this, we got connected with BioReperia and the team of Dr. Gabriela and Dr. Jensen, and then we decided to pursue an approach of testing these drugs in a xenograft model of zebrafish. In the next few slides, I will highlight how these drugs and why we need this model is because 95% of all oncology drugs fail during clinical development. The zebrafish has been shown to be an excellent model to study oncological programs because, similar to humans, once exposed to carcinogen, it develops cancer. The unique thing about this model is that it provides an opportunity to dissect molecular events leading to tumorigenesis. Due to the fact that you can visualize these growing cells within the adult fish or the embryo, it offers a good visualization tool and to study trajectory of the tumor cells. The conservation allows for studying oncological factors. They have, due to the significant biological and genetic similarities and conservation of oncogenetic factors with humans. You can always draw parallels between and also elucidate mechanisms using a zebrafish model. The transplantation tools using zebrafish has been well established. You can transplant tumor cells within adult or in the embryos. It's a highly translational model with superior diagnostic accuracy. They have been used for preclinical in vitro studies, preclinical in vivo, clinical phase 1 to 3, and leading to rapid translation to clinic. Now, with that background, I will hand it over to our zebrafish experts, Dr. Lasse and Gabriela. They will share the valuable insights and research findings on PT compounds using the zebrafish model.
Thank you so much, Dr. Nair. It was a really exciting introduction, both to PT 150, 157, to the issues that we're facing with prostate cancer, and a very nice introduction to the zebrafish field. Thank you very much. So at BioReperia, we're exploiting the larval xenograft models where patients or cell line derived xenografts are created in zebrafish larvae when they're 2 days old. They're implanted subcutaneously in the perivitline area. And you can then study, you can see where it's implanted here. You can then study the effects of drugs over time, study the effects on primary tumor growth or regression, as well as the tumor's capabilities to seed metastatic micrometastatic lesions in this hematopoietic region in the caudal part of the tail fin. The drugs that can be studied are almost any kind of treatment you can think of. We have studied both small molecules that are added to the water commonly or injected into the fish, large molecules such as antibodies that are always injected into the fish, but also even larger molecules such as microspheres that are containing drugs. It could be cells that are either containing drugs or have such a toxic capacity themselves. anything you can think of that will elicit an anti-tumor response can be studied in this zebrafish model. In the same way, you can manipulate the tumor microenvironment almost at will. You can decide if you want the tumors to consist only of tumor cells, if you want to have a representative mix of fibroblasts, innate immune cells, adaptive immune cells. You can either control the composition of the tumor microenvironment, or you can recreate the complex composition of the patient material by simply injecting everything that's in the patient tumor material and recreating that specific environment in the zebrafish larvae. Everything, as shown here, is done within only 3 days. We focus on primary tumors. We also have some studies with lymphomas, and then we instead inject the tumor cells, possibly with other cells, IV, and the analysis is slightly different. As you can see, it's more of a complete tumor burden in the fish, whereas it's a local tumor burden and metastatic profile we are evaluating for the solid tumors. Now, together with Mount Sinai and with pub-taste Palisades, we've tested these two drugs, PT150 and PT157. In our zebrafish tumor xenograft models, we used a solid tumor system, cell line derived models, and we tested the effects of combining PT150 and 157, show you in the next slide, with standard of care enzalutamide, or the effects of either enzalutamide or PT150 alone. Here's an example from PT150, where you can clearly see that the combination of PT150 and enzalutamide was non-inferior to either drug alone, both when it comes to the primary tumor, but excitingly better than both drugs alone when it comes to metastasis. And of note here, enzalutamide was not able to reduce the metastatic ability of these cells on its own, but together with PT150, you could see a dramatic reduction of metastasis. So this was really an anti-metastatic treatment. So what happened when we used the dimer PT157 instead? Well, here we saw a good effect, both of enzalutamide and PT157 alone, but a better effect with the combination. So again, a clear benefit of combining these two drugs. Excitingly, metastasis now was not impaired by either enzalutamide alone or PT157 alone, but the combination of the two had a clear synergistic effect. Now we saw a dramatic reduction in metastasis only in the combination group, clearly demonstrating that the way to go for this drug is to combine with enzalutamide if you want to reduce metastasis, but also that enzalutamide is not anti-metastatic alone. It needs to be combined with PT157 to have any capability to reduce the likelihood of progression in these patients. Now, this zebrafish model is not only used for preclinical drug discovery and development, as shown for PT150 and 157 here. We're also using this very much both to guide clinical trial design or in co-clinical trials or even in clinical practice within the area of precision medicine, where we are interested in understanding the individual variation between patients to treatments. So we can take a group of patients, say that these are prostate cancer patients, test different drugs and see if they might respond differently. This takes only 5 days in the zebrafish model, so this is really clinically relevant. You can implement this in your clinical treatment decision process and then decide, okay, so patient A, that's dark blue here, had the greatest benefit of one drug and could be treated with that, whereas patient B, that's light blue, may have had better effects of a different drug and can then be guided towards that treatment instead. Does it work? We've tested this for carboplatin in a study in endothelial ovarian cancer. Here you could see that the patient models, so these are individual zebrafish patient-derived xenograft models, and those models that responded to carboplatin, they came from patients that on carboplatin treatment had a very long progression-free survival, more than 2 years, so they were clearly sensitive to carboplatin themselves. There were 2 patients in this cohort that had short progression-free survival and was therefore considered not to be responsive to carboplatin. Both of these patients shown in red here showed no response to carboplatin in the zebrafish model. We looked also at metastatic dissemination, and we could do this in more patients. So here you see a larger number of patient-derived xenografts in the zebrafish. Again, the trend was clear that PDX models in the zebrafish that seeded very little metastasis, less than 6, shown with this blue dashed line, they had long progression-free survival, so they did not have particularly aggressive cancers, which was clearly recapitulated by low metastasis in the zebrafish. Whereas those that had short progression-free survival, considered to have aggressive cancers, they seeded more than 6 metastatic cells on average in the zebrafish embryo, again giving valuable information to the clinicians when they're handling these patients. The metastatic aspect and the capabilities of zebrafish patient-derived xenograft to evaluate the likelihood of progression was also studied in non-small cell lung cancer. Here we looked at 24 patients. We had 15 that were having lymph node positive disease when the sample was taken from the lung, whereas 9 did not. And we could clearly see that the lymph node positive patients, they seeded much more metastatic cells in the zebrafish model. They were more aggressive also in the zebrafish. And if we have a cutoff now for non-small cell lung cancer, the cutoff was set at 5 cells. We could identify patients with lymph node positive disease. Indeed, all of those that were highly metastatic in the zebrafish, more than 5 cells, they were also disseminating in the patients, giving very high sensitivity when it comes to predicting the likelihood of progression for these patients. In a study together with a pharma company in Stockholm, we've evaluated whether a drug that they're developing would be more effective in combination with cisplatin or with carboplatin or used alone. And this was done with the epithelial ovarian cancer, looking at to what extent the patients would respond more to the combination or to the drug alone, but also looking at the patients that responded compared to those that did not respond to the drug. You can see the compound here in the middle. Some patients clearly responded. They're below the dashed line, whereas others did not. And looking at whether there's anything characteristic with those responding patients compared to those that were not responding. Information that then helped the company design their clinical study, both by designing it such that the compound was combined with cisplatin, but also designing it such that these aspects of the patients that responded were considered in the inclusion criteria to maximize the chance of a positive outcome in the clinical study. So this is a way where you don't have to shoot in the blind when you're planning clinical studies. You can actually gain valuable information of which patients are going to respond and which are not, design your clinical study accordingly, and then have a much better chance of success. And we think that this is really an important way to go during the clinical drug development phase. For a second company, so this was late in this situation, we did late preclinical drug development for a company. First, we used a cell line together with immune cells to find out which formulation of the drug would be most effective delivering the payload to these tumor cells. We found a formulation that was clearly much better than any of the other formulations, and we then tested this in a co-clinical trial design where they tested their drug already in a clinical study. Some of that patient material was sent to us to look at these formulations, which would be better, and we found that the formulation was effective in a number of patients. We also found that another formulation that was not included in the beginning was even better than the first one. And with this information from the co-clinical trial, real patient samples, looking at a non-clinical stage formulation of the drug, was used in an IND application that was approved. And this formulation was later tested first in man with only this data, only the zebrafish data as the in vivo model. They skipped or were not asked to do any mouse tumor xenografting. Our data here was the only in vivo data used for that IND application, and it was approved. So these are some examples of how zebrafish models can really be helpful, as we've shown with PT150, PT157 during the preclinical drug development phase, but can also be used when you are exploiting patient-derived xenograft models, for example, in the zebrafish system to guide the design, perhaps even for an IND application prior to first-in-man studies, and even later in the clinical development when you're, for example, running phase 2 trials and you need to show efficacy. Don't do this blindly. Be informed by which patients will respond and not respond, and design your study accordingly. And of course, the zebrafish xenograft models can also be used once your drug is approved and used in clinical care, for example, as a companion diagnostic or a way of generating an argument to the clinicians that they should use your drug because you can show that it's effective in a given patient. Thank you very much for listening, and I'm sure that both Dr. Nair and myself will be happy to answer your questions.
Thank you so much, Lasse and Sujit, for such an amazing presentation. Yes, so feel free to write your questions in the chat. So I have some previous questions that I would like to ask you. First, Sujit, you mentioned that these compounds have like an immunomodulatory effect. So is this effect directly like activating the immune cells? And if so, like if it's a specific type of immune cells, or is it general to activate them against the cancer cells?
I think Randy can speak to it, but yes, some of the research that her collaborators have done have shown that it activates CD8 specific responses. So, yeah.
Okay, so have you done some immuno-oncology studies on this, or it has the potential for that?
In the realm of prostate cancer, no, we haven't done anything, but we plan to do, considering that once we establish its role in the oncological programs, and we will go as a next level of investigation to see if it has any direct response on the tumor microenvironment and especially the immune cells. So.
Okay, great. Seems promising. Lasse, you mentioned about the translatability of the Zebrafish platform. So yes, we have here a question regarding that translatability. I mean, being like a fish, how much is this translatability, and how much can this predict?
Yes, great question. I think Dr. Nair touched on this. It may phenotypically look very different from a human, but a lot of the genes are conserved. So even at the molecular level, what is happening in the zebrafish, what is happening in a human is very similar. And the zebrafish model is a vertebrate model, and it's from a molecular point of view, highly translational to human biology. With that said, however, we make a point of studying the human cells in the zebrafish, and are mainly looking at the human tumor cells, the human non-malignant tumor infiltrating cells that constitute the microenvironment within the zebrafish. We can also study the zebrafish's immune cells, for example, or blood vessels in either the growth or the metastatic processes, which we do when we have questions that require this, of course. But it is important to mention that we are studying the patient cells, and even the non-malignant cells in the patient may play a role in treatment outcomes, and these are reconstituted in the zebrafish models that we provide.
Okay, great. And how you mentioned that because, yeah.
Sorry,
Sorry.
Lasse, I have a follow-up question to that. Maybe you also want to, or you could also highlight how these pathways can be dissected, even though there's conservation between both the human and the fish model. There's a lot of, but there are ways, like we've been discussing, about how different approaches, like a targeted sequencing approach or a RNA sequencing approach, can be explored further to understand the specific human programs, you know.
Absolutely, yes. So with current technologies that you can do single cell RNA sequencing and really understand the molecular changes that a drug has, for example, in the human tumor cells. You can even study this if you cut the zebrafish in two in the primary tumor region compared to the metastatic tumor region. Does those metastasizing cells have a different gene expression profile compared to those that stay put at the primary site? And is this changed, for example, by PT 150 or 157, where we saw a clear reduction of metastasis? This can be done because the human cells are slightly different, and you can tease out what is a human gene and what is a zebrafish gene in these sequencing studies. So it's a clear benefit, and it's a great point. Thank you, Dr. Nair.
Great. Thank you, Lasse. Yes. So if you would like to ask any questions, please, Dr. Sujit here just added his email to the chat. Please feel free to contact. If you have further questions, just don't hesitate to contact us via our email as well. It can be to Anna Ekström or our info BioReperia email. So let's see if we don't have any more questions. So I think we can just end our webinar or presentation here. So as we end this webinar, I would like to extend a big thank you to our keynote speakers for sharing their expertise and insights with us today. And I would like also to thank you, each of you, our attendees, for joining us and engaging with your questions and all your comments here. And we appreciate you being here, and we hope you found today's webinar insightful and look forward to seeing you in the future sessions. And don't forget that this is a recorded webinar that it will be available on our YouTube channel, so you can revisit any part of today's presentation. So thanks again, and have a great day, everyone.
Thank you.
Bye.